Thank you very much. Welcome everybody. I'll start again. I'm Dr. Sally Pezaro, introduced by Coventry University. I'm also the academic midwife on Facebook, if anyone follows that, because I love to get nurses and midwives into academia and evidence-based practice. And I'm going to talk to you today about some of my research into psychological distress, workplace wellbeing, compassion, and where that's led me along the way. Just for reference, I am speaking in the lunchtime tantalizer session as well about another part of my research, which is into hypermobile Ehlers-Danlos syndrome in pregnancy. So that's just a plug for that talk then. So I'll start again. This is me. And this was me as a student midwife. And I share this with student midwives and student nurses to help them remember that, you know, I was them once. We were all there once. We all started out. I'd had a different hair colour, thinner and all the rest of it. But it's really important that we remember why we joined the profession, each and every one of us. And I've done this presentation, or presentations like this, a number of times. And I always ask people, why did you join the profession? And never once has anyone come back to me with a negative reason. They don't want to come to hurt each other, hurt babies, do bad things, make mistakes. They come because they want to do good and support families while they're having their babies. So what do you want to be when you grow up? I wanted to be a midwife since the age of 4. Unfortunately, when I was in clinical practice, I myself got very ill. I was diagnosed with post-traumatic stress disorder and bipolar disorder. And I had to go through a fitness to practice process with the NMC to get my health back on track and regain my fitness to practice. So that's where my interest for this research came from. Because I thought, you know, how could I recognise it? How could I have done better? How could my colleagues have supported me? Where did this blame thing come in? And it was all really interesting to me. So that was the kind of basis for this research. So first of all, I wanted to understand the problem. So my first paper was Midwives Overboard. Inside their hearts are breaking, their makeup may be flaking, but their smile still stays on. What song lyric is that? Queen, thank you. Just trivia there. So yeah, that was my paper, kind of pulling all the evidence together, everything I could possibly find on work-related psychological distress, its effects, consequences, outcomes I put into this paper. And I found that the consequences for the midwife were largely compassion fatigue, vicarious trauma, where they were the second victims of secondary traumatic distress. So the woman or the person having the baby or the family being the first victim, the midwife often being the second victim, and then now there's a third victim, which apparently is the organisation, so there's all that discussion. They can often experience shame, guilt, anger, self-doubt, depression. Sometimes it's accompanied with substance abuse disorders and or anxiety disorders, and actually there can be a symptomatic display of unethical behaviours. So if we think of the one midwife you can think of that's always grumpy, always snappy, these kind of the things you think, you know, you shouldn't be behaving like that, especially if we think about how we were as student midwives and why we joined to do good things. How has that happened? And some of the arguments around compassion fatigue and making somebody just lose that compassion might be some of the things we're starting to see in colleagues like that. There's also consequences for maternity services because we have increased medical error. We're finding it hard to secure midwives into the profession. We get higher infection rates and more people die, literally more people die, if the staff are uncared for and in psychological distress. So there's a real case to be made for piling our efforts into making that better. And then, so the sources of workplace distress, really you've got organisational stuff like poor job satisfaction, no promotion, etc., etc. Occupational health, so there's always going to be things in the workplace that are going to cause us stress. The never events, the maternal mortalities, the neonatal mortalities, the stressful events when you're resuscitating a newborn and you're saying, please baby, please breathe. Those kind of things are always going to be stress in heightening for some of us to a lesser or greater extent. But it's always important to realise that stress and traumatic stress is always subjective to that person. So what you perceive as stressful, someone else may not, and equally what they perceive as highly traumatic, you might say, well, that's just regular. And we see that in the women we care for, where they reflect on their own birth experiences. Everyone has a different view. So also I was the author of Safe Spaces, the RCM's kind of latest publication on workplace distress with midwives, but this was actually midwives who are experiencing domestic abuse in their own homes. So I would request that you read that. It's free online with the RCM website. And what we found is that actually women, midwives, largely women, who are being abused, experiencing domestic abuse, couldn't recognise it in themselves. They didn't realise themselves were being abused. And And so that's got huge consequences for, well, if we're screening women who are potentially experiencing domestic abuse, if we don't understand it or recognise ourselves when it's happening, how do we then screen effectively? So all of those things come about. And it's also the same with when we're ill or stressed or ourselves. Do we recognise it? Can we recognise that ourselves, or do we recognise it in other people? Are we good at that yet? Probably not. There's also the Caring for You campaign that came out, and also the Swartz Round. Has anyone heard of the Swartz Rounds? So the Swartz Rounds are a national initiative really to come into hospitals and allow everybody to come along and share in a room the emotional aspects of caring. So if there's been a surgery where someone's cut off the wrong leg, for instance, people would come into the room and talk about that, the emotional aspects of that. It's supposed to be no blame, supposed to be open and honest discussions to support workplace wellbeing in those cultures. However, what they're finding is people who do shift work just can't attend. And midwives, if this is on at 1 p.m, how many of you are going to be able to go to another side of the hospital to attend? So there's problems with that. But these are the things that are kind of going on. And again, there's a lot more evaluation, I think, needs to be done. We put these things in place, but are they working? What are they actually doing? Everyone's signing up to a Caring for You campaign. What does that mean? Is it changing things, or are we just showing goodwill? So I think there's a lot more to be done there. So in terms of help seeking, what I found was people often don't know that they're in workplace distress. They don't realise that they're unfit to practice because of their health. There's also the fear of nursing and midwifery council. So if you say, I don't think I'm fit to practice because I'm ill, you could lose your job, you could be referred to the NMC. We shouldn't be afraid of the NMC, but a referral to the NMC is like, wow, big life-changing event for some midwives, especially when it's not just a job. We know it's not just a job, it's who we are, isn't it? So it's really kind of that threat of, oh, this is my integrity, this is everything I am, being threatened here because of my health. Also, we have this kind of vision of patient comes first, you know, self-service, self-sacrifice, going above and beyond. We have awards to say this person went above and beyond. She didn't just do a job, you know, above and beyond, and we're celebrating that, but actually we might be celebrating ourselves burning out. So that whole culture means that it's very hard to step back and say, actually, I need to pull back for me and my health and well-being. And also the blame game. So, you know, if you're ill, you're a danger, you shouldn't be here. Or if you're making a mistake because of your ill health or whatever, or drug and alcohol addiction, all of those things that come into it, those things that make it difficult to seek help if you're substance abusing, for example, to sort of poorly manage your ill health. How do you even address that? So I looked at perhaps when I was ill, I couldn't verbalise it, I couldn't vocalise it, didn't really understand it, but I might have been able to seek help online, is what I thought to myself. I couldn't tell my manager, couldn't tell my friends or my colleagues, but I might have been able to do that. So I wrote this paper here with Claire Gerarda, who runs the Doctors Support Service in London for doctors who were experiencing ill health. And she wrote this paper with me, and we explored the ethical considerations of seeking help online. Because if you seek help online anonymously, you have anonymity, you have confidentiality, and you perhaps disclose that you are unfit to practice for whatever reason, then because you want to seek help for a good reason, you want to get better. But how does that ethically sit with the direct mothers and babies and families that are within your care and your colleagues? So we explored those ethical issues there. And overall, we came to the conclusion, after looking at the evidence, that it probably was safer to allow people to seek help online, anonymously, confidentially, with a view to get better, with a view to get safe, than suffer in silence, where actually mortalities could go up and the situation could continue. So that was a really interesting discussion. And again, if you get the chance to read this, I'd love to hear your thoughts on it, because people are kind of polar split either way a lot of the time. So when we look at seeking help online, I did a Delphi study. So this is where we achieved consensus with a number of experts. So I asked 185 people, experts in this field, if I was going to build an online intervention to support midwives, what would it look like? What would it have in it? What would it include? So they say it has to be confidential, it has to be anonymous, 24-hour access, we have to be moderating the group chats to making sure no bullying is going on, etc. Discussion forum there, legal, educational and therapeutic components, and a simple self-assessment really, so we can monitor the well-being of people as they're using this online service. That was what came out of that. Interestingly, everyone unanimously almost said, yes, it's got to be anonymous, yes, it's got to be confidential. When I said, well, what about the inevitable amnesty that brings? Oh no, they can't have that. So that's still a big problem in terms of how we support people confidentially when they need to seek help, but they may be a risk to the public. So it's not all perfect. Then I looked at existing interventions. So this was another paper I did, a systematic mixed methods review, where I looked at what's already available out there. This was the stuff that's in the literature. Obviously, we know of other initiatives and things. But there was mindfulness interventions, a work-based resilience workshop partnered with a mentoring program, and then we have clinical supervision. We also now have, obviously, supervision as we know it is gone. So we've got support workers and maternity advocates. But what we found in that review was, although these interventions existed and they were kind of okay at helping, they often require people to do homework. So go away and learn mindfulness, read this book, look at this CD. No one had time to do it. Busy lives, busy family, busy shift work. They still didn't have confidentiality. So even now, when you disclose in a kind of managers meeting that it's said it's a confidential conversation, but actually if you still disclose, I am unfit to practice because I'm drinking 10 bottles of wine before shift or something, then I always use that analogy. If you say that, realistically, it's not anonymous. It can't be. So you can't seek help because, you can, but the knock-on effect is you may lose your job, you may be referred to the NMC, etc., etc. So there were those things that meant that people couldn't attend face-to-face workshops and face-to-face meetings that were going on because of busyness, etc. And then I asked the women. So I did a study where I involved the patients, and it was patient and public involvement, where I asked women, what do you see in the workplace? If I was going to develop something for midwives, would that be useful? Would you sanction amnesty for them? And they said yes. Of course they need to be a confidential space. Of course they need to be able to speak anonymously and seek help without their employers knowing, without this threat constantly. So that was really interesting to note, that they were kinder to us than we were to ourselves almost. They said, of course, and we said, no, we must be professional to the end. And they saw midwives crying in the workplace. One woman said that a midwife actually looked to her for support, a hug from a service user, because she was distressed in the workplace. And they also saw bullying, so undermining, eye-rolling, oh, that stupid idiot midwife doesn't know what she's doing. And one person said they kept having a community midwife come a different time postnatally to each visit, and each one told her how they were better than the last midwife that had been to see them, and they knew better and they'd told her wrong, and yeah. So they see us be mean to each other. They see us cry, they see this. And they attributed that to poor care. They said that directly affected the quality and safety of their care. One person even said, I don't know if it's up there, she thought she wouldn't have needed an epidural if the midwife had been better cared for, less stressed. Because when you're stressed, it breeds, it feeds. It's a knock-on effect to those around you. So that was really interesting. And again, recommend reading that paper. So the solution then, I thought, okay, I do need this solution. I put together securing the evidence and theory-based design of an online intervention designed to support midwives. So that was my case published, and that was also my thesis. That was my PhD finished. Whew. So I thought, what is the kind of solution here? And people talk about resilience, like this magic resilience pill. And I think it's a double-edged sword, because we do need some resilience for those never events that should never happen but do happen, maternal deaths, neonatal deaths, those things you just can't prepare for. But the stuff like bullying, poor workplace behaviours, we shouldn't need resilience to deal with that. That should be the stuff that gets fixed. So it's a double-edged sword, really. And training people in resilience, I don't know, is that even possible? To train someone in resilience? You're resilient or you're not, it's something you have or you don't, a skill you can learn. I'm not sure how that quite works. So I much prefer the notion of workplace compassion. So I'm working towards workplace compassion. So this is a study I did with NHS England, which is the Show's Workplace Compassion campaign. So this was a hashtag. I'm very active on Twitter. So if any of you know me, very active. So I did a study on Twitter where I asked people who worked in healthcare to tweet with the hashtag, what shows workplace compassion? Because you say to a manager, your workplace needs more compassion. They say, well, what is workplace compassion? So this study, 260 tweets told us what showed workplace compassion in the healthcare environment. And these were the things they come up with. So I don't know if it's too small for you to read, but work-life balance is respected. Small gestures of kindness, making a cup of tea, saying hello, smiling to each other, those kind of things breed workplace compassion. And so these things came, again, that's published, so you can read exactly what they said and exactly the tweets they posted. But yeah, in these 4 leadership and management, values and culture, activities and actions, and personalised policies and procedures, we worked out this is workplace compassion, according to these tweets and people who sent them. So then all of that work was put into an NHS guidance documents, because we need to think, actually, what's the driver for making workplace compassion happen? And it's commissioning. People who commission services from staff and trusts, you need to say to them, I will only buy services from you if you can prove to me that you are a compassionate workplace. You don't get the money otherwise. Everyone talks money, money talks. So this was the towards commissioning for workplace compassion, a support guide. So this is a guide, again, freely available on NHS England website, to help workplaces and commissioners commission support and services from compassionate workplaces. And there's also really good hints and tips in there about what other workplaces have done to make their workplaces compassionate. So you can read that document and maybe take it back to your managers and say, look, this is how we do compassion. And if you do that, please let me know, because that's the research really making a difference in practice, which means I can collect that impact and say, woohoo, look what it did. So we did that, and hopefully that's making a difference in practice. It's not been out that long yet. And these are just some of the slides I'll share with you from inside the document. So again, if anyone says to you, this is not something we need to worry about, oh yes, just be nice to each other, la la la, faffy faffy, say actually no, this is going to save us money, this is going to have an improved patient experience, improved safety, reduced absent rates, money talks, 80%, people like figures, people like this kind of thing to kind of make the case for why compassion needs to happen in the workplace. And also, patient and staff experience is the same side of the coin. We don't put the patient first, we put ourselves in partnership, is what I would like to see. We talk about being in partnership with women, in partnership with families. They don't come first, we don't come first. We're 2 sides of the same coin, and if we're not looked after, their care suffers. So it's equally important, is my main message, to look after both sides of that coin. So that's it. My last thing is be excellent to each other. In the words of Bill and Ted, just go forth and be excellent to each other. And I'm out of time, but if anyone does have any questions or wants me to send them the documentation or anything, I'm quite happy to do that for you. But it's been lovely talking to you today. Thank you.